I'm Kathy Eastwood. I'm Associate Director of the Center for Health Informatics for Research and Strategic Partnerships here at the Cummings School of Medicine at the University of Calgary. At CHI, we focus on all aspects of the data pipeline, from data collection and analytics to custom solutions for your research projects. We aim to transform health data into evidence for the community by collaborating and developing innovative methods for health informatics and precision health. This is a speaker series which we host at the Center for Health Informatics to introduce extraordinary work of our colleagues in the domain of health informatics. Today, our speaker is Mohamed Abdalla, an assistant professor in the Department of Medicine at the University of Alberta. He previously was an assistant scientist at the AI Deployment and Evaluation Lab in the Institute of Better Health at Trillium Health Partners. He earned his PhD in computer science from the Large Natural Language Processing Group, the Department of Computer Science at the University of Toronto. His research interests are natural language processing, clinical informatics, AI ethics, and addressing the gaps in translating AI research into real-world clinical settings. His work has received international media coverage from Wired magazine, the Washington Post, Fast Company, among other publications. So please welcome Mohamed Abdalla. So take it away, Mohamed.
Thank you for the kind introduction, I guess. I didn't know you're going to read all of it.
You
Yeah,
can
yeah,
tell
but
us more.
no. Yeah, I'll just go briefly. Why I think this may interest people is that my talk, although it is on AI ethics, and a lot of people have a understanding of what AI ethics is, I take a broader view that is informed by my work at hospitals. So I came from Ontario, and when I was in Ontario, unlike here, the health system is quite fragmented over there. So each collection of hospitals is their own fiefdom. They each do things separately, and that experience has sort of informed a lot of the problems that I face and I talk about today. I won't be talking too much about my own work. My work will obviously be in here, and I will talk a little bit about that. But I sort of want to expand the view by which people consider AI ethics, sort of present hard questions that we don't actually know how to answer yet, just to get, brain juices flowing. Maybe it'll provoke a research interest if you want to do a collaboration, something of that sort. Um, so when you look at the field of AI ethics, whether it is pure or applied, there's largely three main groupings that appear to stick together. And this grouping is not objective or prescriptive, but it's so others may disagree, but I think this is a reasonably good way of looking at it. The first is sort of demonstrations, um, and that's the one that you see most often. It's X does thing really poorly. Here's the negative effects. Like the Twitter bot that was produced by Microsoft is racist or a neo-Nazi. Large language models have these biases. Facial recognition algorithms have been used to, incorrectly attribute a crime to someone, and that has negatively affected their life. And that's very bad, very eye-catching, and that is a decent part of the literature that exists out there. The second piece of literature is what I like to call solutions. And basically, because we have problems, now we must work to get solutions. And these solutions vary in various ways. So some people propose technical solutions to work. Some people propose sort of societal solutions, the data collection, like it's a data cleaning thing as opposed to the model. Some people focus on the model, some people focus on the application. There's no agreed upon consensus, and this is not really the focus of the work. And the last thing, which I think a lot of people have not heard of, but is more common in sort of the field of health, is called meta AI ethics. And this arose to respond actually to the solutions. So why do the solutions have the limitations that they do? Basically, what is the study of environment that ethics takes place in? We explore themes, trends, and sort of the body of AI ethics as a whole. Ask questions such as who funds the research, what values are embodied by the research, how do each of these align with what we want to do? So first, I'll just present some very brief work demonstrating examples of AI bias, both on societal and non-societal factors. So the spiciest, most news-catching form of AI bias is societal. So for example, previous work has that we've done, as soon as you see this example, you know what's going to happen. So there's bias in clinical large language models. We present, race, a placeholder for race so that we substitute, became belligerent and violent and was sent to, and we let the model predict the green tokens. And you know what's going to happen. If the patient is Caucasian or white, that's what the replacement for race. Then the next prediction is hospital with a period, and that's where they were sent to. But if the patient is African, African American, or black, they are instead sent to prison. And if you are using, clearly this is a problem. And the issue here is it's not clear how to search for a solution. Why is this not obvious? Because disentangling the source of bias is a momentous task. We don't know if the bias is coming from the doctors used to create the data set, something we hate to assume, but historically has not been, you know, too rare. It could also be from data imbalance issues. So, for example, the hospital is right beside a prison, and because of other societal biases, the population in that hospital often comes from the jail, and that's causing overrepresentation of people being sent back to jail. Um, or it could be something more systemic, which many models have suggested. So incorporating such thinking into the creation of these models is non-trivial, and it's a very large hurdle to the adoption of large language models, although a lot of institutions are trying in the clinical setting. We tend to see that models trained on healthcare data tends to perform better for the majority group. So this is something that I want to highlight here. It's not in our setting. The majority group tends to be sort of Caucasian, at least when it comes to race here, and it will present better and it will perform better in that way. But it's not like all models perform better on all white people. For example, at a previous institution that I worked at, we were testing a model that came from an Asian country, and it performed better on patients from that Asian country, even though we're testing it here, even though technically they are a minority here. So that's something that's also, yeah, interesting to think about, but also makes it very difficult to fix, basically. Um, and some biases are correct. So there are some sex risk differences. So completely removing all biases is not appropriate, but correcting biases is challenging. So that's just something to think about. But also, these biases exist in something that's not just societal or social. So, for example, at Trillium Health Partners, at my previous institution, we evaluated a binary X-ray classifier to help triage patients when they come in, so see for radiologists to read them. And basically, an image would be a study would be normal or abnormal. And you can see the traditional performance disparities here, and these are sort of all social groups. So you have age, you have male, female, some sort of race, because we don't collect formal race data. We have to infer this by name. And you see some differences here. And so, for example, there's a large disparity between ages, which we can expect because, there's the prior for different age groups is different. But something that was unexpected, that we did not expect, was that we also saw quite large performance disparities for the machines being used, and we don't know why this is the case. So there's a absolute 22% change in the specificity or sensitivity depending on which model the X-ray is taken on, and that's substantial. And we don't know how to fix it, and we don't know why. And these and we're not using like weird unknown these are brand names approved by the proper sources. So it's unclear why this is the case. And the algorithm itself was also approved, so it's interesting to think about. Another issue, is race correction, and this is something that is being more recently highlighted by AI ethicists, and we have a paper that's under review on this. Traditionally, race correction is the practice of correcting, i.e., adjusting diagnostic tests or any other tests, usually for Black patients, but technically for any race. And here I just demonstrate a very simple example. So you have a patient, and they get a specific number in their blood test range. If they were white, they missed that range, and so they would get sent to they need kidney care. And if they're black, the range is a little bit expanded, and they're within that range, so they say no kidney care is needed. And this has implications, and this illustration is a very simplified form of doing it, just for the sake of time and for the sake of the presentation. But it's not that simplified. For example, EGFR, which depending on your institution, I don't know in Alberta, I've not talked to anyone who actually works on this, but in Ontario, some hospitals are using it and some hospitals are not using it. So there is no agreement in Ontario with how it is done. And EGFR is commonly collected for people classified as black by the healthcare system. And the issue is we don't actually collect what black is. So it really depends on your physician's reading of you. It's not even formalized where you self-identify of anything of that sort. But you can see that, you multiply the result by 1.159 if you're black. And this results in a different number. And this is actually explicitly noted in the test result that you get. So on the right side, I have a picture of it, but I just wrote it to make it easier to read. And it tells you that, for patients of African descent, you must multiply this number. Um, so what does this mean? A black patient with the lab test result that is the exact same as a white patient would get treatment started later or be deprioritized for transplants. Again, the main issue, this is not, the main issue is that this number is not based on robust evidence. There's no biological mechanism for this. And, there are harms caused by this if it's not true. Also, how do you define black? Like, are North Africans, Egyptians black, or like, is Sudanese black? Because you're right. What about white South Africans? Like, is it just this by African here? Do you mean black, or do you mean the continent of Africa? What do you do when it's mixed people? Do you multiply by like 1.07? It's unclear. The instructions are not there. And I just, the issue here is that it's not trivial to fix this. So in the clinical setting for EGFR, when they decided that there was not enough evidence to continue correcting for race, what they decided to do was basically de-adopt the standard equation and adopt a new equation that did not incorporate race. And this works generally. The doctor now will, if you have the same test result, regardless if you're white or black, you get put in the same pool. The issue is that when you're training AI models, you're training it on historical data. So it is much more difficult to correct race correction in AI. For example, let's say a hospital which did not use race previously, which used race previously in a race corrective format, chooses to no longer use race. The issue is all of their training data that is historical is trained on race corrected data. So it will not, you're going to be making improper predictions, basically. So a lot of people who had lower scores or higher scores, depending on the specific test, will be misclassified because it still thinks that you're doing race correction. So because your gold standard label has been affected by the race correction, and it's very difficult to correct whether or not the doctor would have back in the day changed their classification, and that would have changed their outputs. It's a messy process, and it's not simple to do. And as such, it's very difficult to correct race correction. And this is to end race correction when it comes to the training of AI. This is the paper that's under review, but basically it's not as simple, especially in the field of when you're applying AI models here, to just change the equation. There are problems with each of the like naive solutions, and I don't mean this in a negative way. It's just the obvious solutions that spring to mind don't work, and we go through each of them and why. So my most popular work, my favorite, I guess, deals with the funding of academia, especially when it comes to AI ethics, especially within medicine. So meta AI ethics is a new term where we explore structures that affect how AI ethics develops. So there are many different things that it can affect how we view the research that we do, the types of questions that we ask, the types of solutions that we propose. For example, sort of widely accepted is that the diversity of people doing the research or taking part or talking about the research, for example, the effects of AI, will affect public perception, the types of views being platformed. Another thing that affects the types of research being done is the funding sources, and that's what I'll jump into next. So let's consider this unusual conference. You have a health policy conference with 10,000 plus attendees that was largely funded by Big Tobacco. And among the variety of topics that they discussed was the negative effects of increased tobacco usage and how to sort of deal with the negative societal consequences of increased tobacco usage. Would this be accepted in the health policy field or healthcare? The answer is no, this is unacceptable. The World Health Organization's Framework Convention on Tobacco Control states that you have to basically protect against commercial interests when you are doing health research. However, if we switch this, and now you're doing a machine learning conference with 10,000 plus attendees, and among the variety of topics that are being discussed is how to deal with the negative effects of increased AI deployment, would this be accepted? And the answer is that this is not even theoretical. This is the state of the art. All of the big conferences that exist, whether they're AI ethics or pure sort of technical machine learning or a mix of both, these are the biggest two. Fact, fairness, accountability, and transparency, sort of a ethics conference for computer scientists and others. Neural information processing systems, NeurIPS, is largely technical, but it has an ethics component as well. Um, it's accepted. No one bats an eye. There's no discussion about whether or not this should be the case. What should we be doing? It's just sort of taken for granted that this is the case. And the risk of corporate capture is not theoretical. So after I published this paper highlighting it, and I'll talk about the results in the next slide, it came to the attention of media that companies have been actively censoring the work of researchers, as Facebook did with mental health when the whistleblower came out, or Google has tone policed their researchers in collaboration with academics. So, for example, it was revealed that Google told a scientist to strike a positive tone in AI research. Basically, if the results of your research was not going to improve their bottom line or the stock price, you were told to either shift the messaging or don't publish. And I personally know people who are academics who got censored because one of their collaborators is employed by one of these companies. And so it's not theoretical. And the question is, this doesn't require bad intention by any of the involved people. So I'm not saying corporations bad. I'm just saying one must understand the incentive structures that exist and how they affect the research that we do. And this applies to academics as well. Even if you are not doing, even if you're not collaborating with them, you're often seeking their funding. So we surveyed the CVs of faculties at top research schools, computer science departments within the US and Canada, and found that 58% of professors have received direct research funding from these companies, and 97% have either received funding or worked for them in the past. And the claim that we're making here is not that interacting with them makes you a bad person. For example, I interned at Google during my master's degree. It's just that it increases the chance that you adopt their viewpoints and internalize some of the limitations that they place on the work that you do or fund. For example, let's say we want to tackle a specific problem, and I need to get funding for that problem. I will take into account the views of the possible funders that could fund me for this specific problem. And what you end up seeing is that for any problem that we have is always a technical solution being proposed. And AI is being framed as inevitable. AI ethics is always a discussion of how to reduce the harms instead of sort of what are the proven benefits and are there more effective ways of improving the outcomes instead of dumping $3 million into this specific AI program. What if you use that to hire nurses or something like is that going to have a better impact than deploying the AI thing? But no one's going to fund me as a computer science researcher if I say that actually we should just hire the nurses, but I need to get tenure, which means I need to get funding. So now I'm going to propose something, which will be an improvement. I think that a lot of the work that we are doing is good, but there's not as much discussion on is it as good as it can be? Are we truly optimizing at the societal level? And I think that's yeah, this is just something to think about. Again, I don't mean this to be sort of moralistic. For example, like I said, I interned for these companies. I have not yet received funding from them, but I may have to in the future. It's not a moral thing. It's just the incentive structures play a role. We acknowledge this generally within health research, but within AI ethics or health AI ethics, it's not acknowledged. And I just wanted to present that sort of difference. So I guess the last part of the talk, I'm going to be presenting questions without answers. Just to get the brain juices flowing, maybe it'll start a discussion, maybe it'll start research questions, something of that sort. So the first thing is, what is fair? So there's within the computer science community, there's largely AI ethics community, there's largely two definitions of fairness. There is individual fairness, which is basically like should be treated as like, which means that people who are similar to each other should be treated in a similar manner. What this means is that if you have 5 perfect clones of me and an algorithm predicts different outputs for the exact same input, or my clones basically, and we get differing health outcomes, then whoever got the bad health outcome was treated unfairly. The model is not being fair. The question is, how does one define likeness? Well, what are the set of features that we should select? because we know there's a ton of things that have effects on health, the income, the employment status, the housing situation, your genetics, among many things. Uh, yeah, defining like or a measure of similarity is non-trivial, especially because we don't have access to this data. It's not clear that we want to collect a lot of this data. A lot of it is very personal data, and patients may not feel comfortable giving it to us, and it's cost prohibitive to collect for many institutions. So, since this is very difficult to do technically, often what we do is group fairness, which is basically algorithm performance should be equivalent across all relevant groups. And here we leave it to the users to define what relevant groups are. So you could be talking about race, you could be talking about sex, you could be talking about gender, you could be talking about age. Basically, it has to perform equally well within noise or within some acceptable threshold across whatever groups that we are talking about. And right now, the majority of work uses group fairness definitions over, sorry, for protected attributes. But is this necessarily the best definition? And how do we go about justifying it? Or how do we go about defining more relevant groups? For example, we'll go back to race. How are we defining that? It's unclear. Um Even when you're defining it for sex, you're losing a lot of the sort of intersectionality that's at play. So rich versus poor will also have an effect. So group definition is not necessarily the best fairness definition. But I like to go sort of structural. I don't care what the best definition is. The question is, how do you go about deciding what definition to use? And the main issue is that there isn't an agreed upon way for how to do this. At the hospitals that I have worked at, they have different methodologies. Some hospitals have like a decision-making committee, and they're the ones responsible, and they take the fall basically if they get on the Globe and Times or like the Toronto Star or whatever. Some other hospitals leave it to the individual clinician or like clinician group, like sort of departments. Let's say if we're talking about radiology, who's deploying the algorithm. It's up to them to define how they want to how one they want to define fairness, but two, what is an acceptable disparity between groups? Yeah. So I don't like the lack the wide diversity is good in terms of brainstorming ideas, but I think that there should sort of be a standardized way of thinking about this, of how does one go about defining fairness in any specific use case? Or maybe there's different ways. What's the process for going about defining this? Um, the second question, I guess, is how does one deal with race medicine, which I highlighted previously. Basically, the main question is how can we enable more equitable outcomes without further entrenching false categorization? So we know that race is not a neat scientific category. So is race necessarily the best categorization and evaluations for these algorithms? What are the larger societal effects of continuing to propagate differences in this manner? So for example, and I don't know if anyone here works on diabetes, but at a previous hospital that I worked at, sorry, I'll step back 1 second. When we talk about race and we use black and white as the example, it's sort of, there's a very heavy cultural context that is at play here that makes it very clear that it is sort of bad and there's like sort of a malintent that we attribute to previous researchers. But this is not always necessarily the case. And I think, it's good to give benefit of the doubt. We see, for example, that for diabetes, there is specific, um, for South Asian, like efforts for the South Asian community. This is exactly this is race correction. Whether or not it's appropriate or not, I don't know anything about diabetes to tell you whether it is appropriate or not. So I'm sidestepping that conversation completely, just sort of raising the point. But we are still doing it. The question is how, on what basis are we doing this? Is this necessarily the best way? How do you deal with the negative sort of ramifications that could arise from this? I'm not saying it will all be negative. I'm just saying, again, standardization of processes is what I care most about. I'm not saying it's always inappropriate. I'm not saying it's always appropriate. I'm saying how do we justify it, and what is the process for which we can justify this, such that at least we're standardized in this way. Also, should models be allowed to make different predictions depending on the ethnicity of the patient, or should ethnicity only be used as a stratification variable when doing evaluation? There isn't clear-cut answers. There's different solutions. Sometimes there's genetic diseases where ethnicity or race might need to play a factor, and others where there isn't an understood mechanism. Do we need to wait until we understand the mechanism to act if we see that it's impacting one group more than another? Difficult questions. I propose no solutions. The last thing, which I think is sort of the easiest to talk about, is let's say we have, and I've encountered this at multiple hospitals I've worked at. Um, let's say you're a hospital director or the director of a program, and you're deploying your task to improve wait times, something that a lot of people are worried about, understandably. And you plan to do this by deploying an automated AI tool to relieve the doctors from having, uh, to deal with low acuity patients first, making the higher acuity ones wait and increasing wait times overall. So let's say these are your current wait times. So white is at 85, let's say minutes, black's at 90 minutes, and Asian's at 95 minutes. And lower is better for wait times. The majority of existing fairness AI literature sort of frames the question of achieving equal performance on some predetermined metrics. So, right, we want to improve wait times for everyone. And how do we go from 85, 90, 95 to 80, 80, 80? And now they're all equal and we've improved it. And that's, it's fair and better. However, this is an unrealistic expectation of how algorithms perform. Very rarely do they work in this specific way, and in the way they actually do work, they present to us much more complicated questions. They don't really bring people to the same level. They don't even improve people by the same amount as can be seen here. In truth, you're more likely to get larger performance variations. So, for example, in the first model, black patients have an improvement by 5 minutes, and Asian patients have an improvement by 10 minutes, whereas white patients do not have any improvements in wait times. You have increased the fairness insofar as the differences in wait times are now reduced. But if you frame fairness as an improvement in decrease in wait times, white people have not had any improvement. So technically, it's not fair to them in a way. Like it depends how you define it, but like from that perspective, it's not fair to them. Another type of model, for example, again, these are all hypothetical numbers, is you improve the wait times by an equal amount for everyone. So white people are reduced by 5, black people are reduced by 5, Asian people are reduced by 5. So now it's basically the exact opposite of the previous one. The gaps between the groups are still large, so it's unfair in that way, but the improvement for all groups is improved, and that's better another way. So even if you take an equity lens, it depends. Are you taking equity in improvement or are you taking equity in outcome? And it's not it's not as simple as just switching the word. I think this is actually difficult. And the last model, for example, which is something that we see often, is for white patients, the average wait time has decreased by 5 minutes. For black patients, it has increased by 1 minute. And for Asian patients, it has decreased by 15 minutes. So the average time has actually decreased for the majority of patients, but it has worsened for a single group. Not by much, but it has worsened for a single group. What is the preferred? How do you choose between these three models? Again, I think that depending on your use case, depending on the specific disease, I'm not an actual doctor, so I can't tell you which one should be used. You know there's conversations to be had. It's just that there's no standardization. I think there's not as much thought that's not true. I don't want to insult the field. Uh, there's just a lack of standardization in the approaches that are happening. Um, I think that one could make a convincing argument for any of these three, and we should have arguments for all of these three, and then we should debate the proposals. I just think that, you know, we need to establish process guidelines for answering these questions. How do we hold ourselves accountable? Is it at the hospital level? Is it at, the Ministry of Health level? Is it, academic and there's going to be an international standard that most people apply? What is the best way of doing this? And it's unclear. Uh, yeah, and then who should also have a say? Is another question. So is this going to be an expert that's making the determination? Do we involve patients in this? There's how do we convey the work that we are doing to patients and make them, not detest AI? There's a lot of like negative feelings towards it. There's a lot of, especially I guess in Alberta compared to Ontario, though it's growing in Ontario as well, sort of hesitation towards accepting testimony of experts or academics, and that's something that we have to take into account when we do these sort of conversations. Is that it should not be reserved solely for the academic realm. It should be also, you know, involve the larger public as well. Uh, and that's my presentation. Sorry for presenting more questions and answers, but I thought it would be more interesting to you guys. My main area of research is natural language processing, but you guys already had a speaker on natural language processing, so I thought I'd switch things up and give you something that I thought was interesting. Thank you.
Thank you, Mohammed. That was awesome. I have a question about standardization. If you say that you care the most about that, is it because then trying to do a predictive model in a different setting with a different model will achieve a different result, like so that when you share one model between settings, you're going to get more standard information? Tell us why you feel that's so important and how should we think about it?
Yeah, I was thinking more standardization in terms of processes than specifics, with respect to models. I think that models, yeah, they don't generalize well. So we have tested this among multiple hospitals. They don't generalize well. So you will not get the same performance across models. Like for example, you can deploy a single model and you get like the first group here versus the last group here, and that's something that you can expect to happen frequently. Um, I don't think there's a way of preventing that from a technical perspective. There's works to improve generalizability, but they're not there yet. Uh, I just think that in terms of process, got when you get a model and you get these results, how do you determine if you are happy with them? How do you determine if it's acceptable? How do you determine which of these two is preferred? That's sort of what I meant by standardization. Standardization in terms of process, not in standardization in terms of model. I don't think that the data gathered by different institutions is very disparate across provinces. I don't think it'll be possible to get standardization feasibly within a reasonable time frame on that front. I know there's people working on it, and I applaud their work and I appreciate it. But yeah,
Okay, thank you. Feel free to raise your hand and we can take your questions. Or if you feel more comfortable, write it in and put it in the chat. But it's good to have some discussion going. Certainly, this is a challenging topic. Um, who would like to ask? Elliot?
Hi, thanks for the talk. This was great. Yeah, there's just so much to do in this topic. Um, so we're also doing NLP stuff, and we're interested in extracting social determinants of health. So you can even start to approach these things, because one of the problems I think is that we don't collect a lot of this data. So even if we want to do like fairness corrections, you really can't for most stuff. But then you run into the question of, okay, what data do you actually want to collect? And then how do you define race for your intensive purposes? Um, so how do you even like principally sort of go about that? Because there's so many, it's just like a deep rabbit hole of like cultural constructs, and like, do you get people's, self-reported ethnicity, or do you really care about, do they look like a visible minority? So is the person going to be prejudiced against that? Like, how do you think about starting to disentangle these sort of things?
yeah. I mean that is a very good question that we also struggle with ourselves. It really depends on the use case. The example that you mentioned at the end was perfect. Basically, like when you talk about ethnicity, is it because of how people perceive them or how they perceive themselves? That's an important thing. There's also, like I know, for example, there is sort of activist groups, at least within Ontario. I don't know if they exist out here that were against the collection. There were hospital efforts in Ontario to try to collect race-based data, uh, ethnicity, and to inform fairness corrections and anything of that sort. And they were against any sort of effort by the hospitals to collect their race. They knowing that it would forbid researchers from searching, sort of doing the sort of ethics research that we want to do. And their main concern was that as soon as it is under the sort of the ownership of the government, it will be shared with police. Um, and that they ended up being right during COVID. Race was shared with the police in Ontario. I don't know about here because I'm a new transplant here. So like there's a question of, do people even want you to collect it? Which is a difficult one to answer itself. And I think that like there's the expert viewpoint of like, okay, we want to do this work and it's important to do this work, so we're going to do it regardless of whether or not you want to do it, which is a viewpoint that some researchers take, but at the same time that could backfire if it, depending on how it goes out to the public, that's something that you would not want, right? You have to balance this as well. I think let's say you pick something where your population is happy with you to do it, you just don't have the resources to do it. Um, I'm of the opinion, and some very strongly disagree with me on this, and I've got some of my work attacked in the past for this, and I understand why. Of like, don't let perfect be the enemy of the good. So, for example, we wanted to do a sort of diversity analysis on authorship in sort of journals, and we used names to do it. There are issues with that, many issues with that, but like there was no other way. It's either we don't do it or we do it. And there's some people who are principally against it, and I totally understand them. And but I did not hold this principle, and it's just sort of like a negotiation that you can't win, but like you just have to engage with it in good faith, and you just case by case, I guess.
Yeah, we had I know one of the researchers here, Huda Kwan, had a similar algorithm for race with last names. That's sort of like, you do the best you can with what you've got, sort of thing.
Yep.
But
Yep.
yeah, it can be a mess.
Yeah, yeah, and even like especially in Canada, so like the rate of like like interracial marriage, it feels weird using that term because it's often used in a bad context, but like there's a lot of people who just like it's not that indicative, especially a couple of generations down. For new immigrants, it'd probably be pretty accurate, but for later immigrants, like I don't even think it's that accurate really anymore. Yeah.
Yeah. Um, we have another question. Bida Albandar, go ahead.
Yeah, thank you very much. It's very interesting talk. Yeah, thank you. Yeah, I mean it's very interesting topic. We already developed an paper we have, which is currently it's under review, that consider the issues you have mentioned. This is the reason why we are very interested, myself and Marco, and we have joined this meeting. I would like just to discuss some few points with you regarding the ethical sides. We have considered different algorithms from traditional machine learning to deep learning in this study until even large language models. So we have considered how to detect the bias and to consider and investigate some debiasing methods. The question is, what is the possible and what types of, for example, of research you have conducted in your university or research group regarding developing fairness-aware algorithms? So rather than focusing on developing algorithm to detect the bias and eliminate it using a separate method and dedicated method for debiasing, it would be good to have some progress in fairness-aware algorithms. So is there any progress you could share with us if you do research with people that they are focused on, computer science and technical side? Just would like to have, an idea what other people on what are the other group doing in terms of research.
So this interesting application. Unfortunately, my main research area is sort of evaluative methodology for computer science algorithms. So I don't do much sort of development, at least not yet. And I don't know. I'm new to the University of Alberta, so I'm not 100% sure if there's anyone working on fairness-aware algorithms, but unfortunately, I can't.
Yeah, okay, thank
Yeah,
you.
sorry.
Yeah, no problem. Another thing that about the data sets, now the most challenging thing is if you, for example, if you wanted to study a specific problem in the domain, for example, in healthcare, regarding a specific domain in the healthcare, you would need to bring to study the bias in a specific data. And if you'd like to move to study in another domain, it will be a challenging again to generalize the finding you have found in another data set. Have you encountered a problem like this, and how you try to manage this issue from ethical point of view, from I wouldn't say that technical point of view, from ethical point of view? Have you encountered a situation like this, and how you did consider the issue?
Yeah, so I guess I'm starting in Alberta, so most of my answer will come in the Ontario context. It's a little bit easier to get access to data in Ontario because usually you're employed by the hospitals who are the data custodians, and since you're employed by them as researchers, it's relatively easy to get access to them. Also, onboarding students is much easier than here in terms of onboarding them into the healthcare system, not onto universities. So data access is not that much of a problem there. The wealth of data is better here, but data access is a little bit easier there. Um, in terms of defining it for a specific problem, I don't think that's necessarily an issue. You have to, when you approach each task, you have to tackle it in a different manner because the population being served or sort of evaluated for is different. The specific concerns that you'll have for that population or for that disease or for whatever should also be different. For example, like with the X-ray thing, the machine is something that you now need to evaluate for in terms of fairness, but that would not necessarily apply for other something where a machine isn't used or everything is using a single machine. So I don't think there is a way of yeah, you can use the same process for multiple use cases, but I think that at the end of the day you have to involve clinicians to help. They have to define for you what is the most relevant
Mm.
things here for you to look at.
I see. Yeah. Thank you very much for the discussion and for the presentation.
Thank you.
Just a quick comment from the chat. It's basically Frank's highlighting that privacy laws are changing in Alberta and that anything submitted or requested related to automated pseudo-computerized algorithm-based decision-making systems, including AI, will get flagged and trigger a privacy office inquiry. And it may it will need to fall into compliance of the health system. So they're being quite closely scrutinized, unfortunately, because it limits some of the exploration in this area. Adam's got a question. Go ahead, Adam.
Thanks, Kathy, and thanks, Mohamed. I found every single thing you said incredibly interesting. The thing that I was the most interested in, it was a difficult choice though, a hard choice, was the stuff that you were talking about vis-a-vis technological determinism. So sort of the idea that this is the kind of we should be using AI models basically in every aspect of society. And that provokes a lot of anxiety in me because I suspect that that is not the case personally. For people like me, is there any reason to be optimistic? Is there anything at all that we can do to fight back against the tide of encroachment of AI into areas where it doesn't belong?
So that's a very hard question to answer. So I think is there a reason to be hopeful? I don't know. I guess naturally I do this work because I'm trying to push for something, so, which is in a way means that I'm hopeful that change could happen. I guess that's why I'm talking about it, sort of trying to raise awareness. Is it rational what I'm doing? I don't know necessarily. I think that you know organizing largely the issues. I'm not a social movement scholar, so how does one most effectively advocate for the position that they want is sort of outside of my scope of research. I think it's possible. I think that there's a lot of money behind pushing the deployment of AI, and there's a lot of use cases where it will work, and a lot of use cases it will not work. And I think that if you let's say one is planning how do we push the view of let's not deploy everywhere. I think it's capitalization on failed instances of the deployment would be the most effective way of doing it. The question is by who, how, when, the resources for it. That's a question that I don't have the expertise to answer, but I think that it could be done. I think that there's it has happened with previous technologies before, where the hype cycle is making it seem like it's going to go into everything, and it doesn't actually end up going into everything. And I think that's likely what we'll see here as well. I think we're just on the upward trend of the hype cycle, and eventually it will stop. It has stopped before. It'll probably stop again.
So,
yeah.
so people just need to start noticing that it doesn't actually always help.
Yeah,
in a way.
Basically, yeah, and you just highlight those cases and oh, what if we had done this instead? Instead of hired the nurses or reorganized this thing instead. That could have had an equally good effect, kind of thing. Yeah.
That's great. I hadn't even thought about it in terms of the hype cycle. That actually is very comforting. Yeah, okay. So that's awesome. I also just have an incidental remark, which is I'm an immigrant and I'm originally from India, but I'm aware that a number of databases think I'm from Portugal because of my last name.
Yep.
So just thought I'd put that out there.
Yeah, which is fair. I mean, so our name-based algorithm that we used in the past we use a U.S. Census because they have for all of their last names, they classify them into their 5 categories, and I'm white. So I'm very familiarly aware of the limitations. But yeah, it's sort of enemy. Don't let the perfect be the enemy of the good sort of approach. It just unfortunately.
Yeah, for sure. It wasn't an accusation. It's just a piece of trivia.
Yep.
Thanks a lot.
No, thank you.
Any other comments? Elliot, go ahead.
Sorry, one more. This is an interesting topic, of course. So not to put you on the spot, I know these are all like there's no easy answers for any of these, but you've have thought about this for a while. So how do you think about like the trade-off about making things better for the most people possible versus making things fair across groups?
Yeah, okay. So this is like a very spicy topic, and it's not
Yeah.
trivial to solve, right? It's very difficult. Like okay. Um, I think, and this might be like I guess like a cop-out answer, but it's not a cop-out answer. I actually do believe this. Going either way in like going to either of the two extremes is not helpful. So going solely ignoring any sort of subgroup concerns and just going we are max utilitarian, we want the average drop in time for everyone is not. I don't think it's sort of like yeah, I don't think it's necessarily the best way. I have a hard time justifying why, but my intuition just says that like it's probably not the best way.
I mean, it feels really icky in some ways to ignore
Yeah, because in
like
the same
all these
like
subgroup problems.
exactly because like I mean like if we take it out of healthcare, let's say for example, majority group A in a country votes to own all of the property of majority group B. It is the will of the people, and the more people will be happy, kind of thing. Yet we don't allow this to happen usually, right? So I'm just applying that same framework of thinking to healthcare. It seems like it's probably not the right way, but at the same time, ignoring everything, like going. Unfortunately, we live in a like sort of there's limited resources that exist in society and that can go around, and we have to put that into account as well when we're trying to improve. Like we have to be effective at the way that we deploy our resources to have these improvements. So you could deploy an AI model for every individual person to maximize the improvement for every individual person, but we don't do that either because it's highly ineffective. So some level of grouping has to be used, and some level of societal metric has to be used. I think it really depends on the specifics, and it depends on the existing gaps as well. Um, yeah, like it's unclear to me. Yeah, like if, for example, there's a group that has historically been discriminated against, I think you could easily make the argument that we want to deploy this AI model and focus more of our resources on that group to improve the performance for that group. I lean towards that argument. Like that has a appeal to me. But if you're not correcting a historical bias, I would lean towards more the equal one. But then you're functionally creating in 20 years a historical bias that will now exist. So it's not clean either way. Yeah.
Yeah, no, it's a hard problem. But then you have to think that there's going to be someone who has to explicitly decide this at some point, right? When they make these algorithms, like I don't envy them at all. That's got to be a terrible sort of thing to do, but to make these trade-offs, because eventually they'll have to be explicit if they're going to actually code them into the systems.
Yeah, exactly. Yes, I think that we have done this before in the healthcare system. Like transplant lists make some very
Mhm.
hard decisions. So like I think there's precedence for having like decision making groups and like sort of guidelines for how to do it. And that's sort of what I'm pushing for when I say standardization. Like I don't think it should be up to me or you to just like think really hard and like decide and hope that we made the best decision possible. I think it should be institutionalized. That way, if people don't like it, it can be changed as an institution as opposed to every individual's department and every hospital is making their own decision, and then it's like your luck depends on which hospital you go to, sort of thing.
I sort of like that idea of like a transplant group sort of panel versus AI to have these kind of discussions. That seems like a reasonable way to do it.
Yeah.
Thanks.
No, thank you.
Sure. Adam, one more?
Yeah, because Elliot asked a second question, I was emboldened to as well.
Okay.
Okay. So my second question is, I guess, so in some ways, I guess carbon is like the classic externality when you're analyzing system level ethics. Like as one of the classics anyway. Are you aware of work that's being done to sort of quantify the environmental cost of all of the compute that's necessary to power these models? Like even independent of direct harm to patients or members of society?
Yeah, yes and no. So yes, so Sasha Luciano, I'm probably butchering her last name. Uh, but Sasha L, she works at Hugging Face. I'll write the Sasha L. Hugging Face is a computer science startup company.
Yep.
Weird name, but yeah, just in case. But she has a lot of work where they try to quantify sort of the greenhouse emissions depending on the model, depending on the like server that you go, depending on the geographic region. So she has a lot of good work, and like she cites a lot of good work. Like she's in that area, aware of her research. Um, I don't think they've applied it to healthcare in terms of like what are the healthcare effects of the increased carbon. So like there's a positive by the deployment of the algorithm and there's a negative caused by the deployment of the algorithm. And like, do they cancel out? Do they not cancel out? I don't think that has been done. I think it's difficult to do, but very interesting. But there has been work sort of trying to produce estimates of greenhouse gas production or emission because of the deployment of models.
Yeah, okay. That's interesting to know. I'll look her up. And I guess the same can be said about like mining.
Yes. Yeah. Yes.
But like you need all the chips
I
to
don't
build
think there has
GPUs.
been quantitative work on that yet. There has been Kate Crawford, I think has like the life cycle of AI or something, which goes from like digging in the ground all the way to deployment and what are the externalities caused by each of these steps. Loose way of describing it. So that work exists, but it's not, I guess, quantitative insofar as you would not be able to use it to like, like this many chips causes this much X. But it's more qualitative than it is quantitative. But it's still good work, which you could read if you're interested.
Awesome. I appreciate the tip. Thanks.
Any last questions before we wrap up? Oh, we got one more from Marco.
Sorry. Yeah, thanks again. It's a very, very fascinating topic and great talk. Just I wanted to ask you, what's your view on the regulatory efforts that are done in this regard, basically, because it seems like it's also, especially in your field, I mean, well, clearly, Wade and I, we are from the other side of the ocean, and there is a lot of discussion about regulatory, so the AI Act, and I was basically last week, there was a talk about ISO standard for 2001, that they are discussing yet another quality assurance regarding the use of AI systems. And it seems like even from the technical point of view, as you were discussing, it's difficult to define those things. So it seems like it's even more difficult to regulate them when we don't have a clear understanding from the technical point of view. I remember in your talk back in the day when ChatGPT came out, I'm from Italy. In Italy, there was this huge discussion because of, again, ChatGPT is gonna revolutionize everything, and it was banned literally for a couple of months, I think, which was a very weird thing anyway. I mean, it's even impossible to ban. So, what do you think is are they futile, those efforts, or is there any way to regulate all those issues?
So in terms of like any single answer is too broad because there's too many regulatory efforts like I'd be wrong in some way. I don't like some efforts probably are futile, some efforts are not. Like I think the banning would be futile, but some of it would not be. I think that I'm more two perspectives here. I think that regulation that directly affects a technology likely is not by directly affects. I mean like legislation, like you cannot use ChatGPT to do X. That doesn't seem to be like it seems like again, I'm not a policy expert, unfortunately, but like it seems to me like that would be outdated very quickly. So I don't think that's necessarily the most fruitful path of going about things. I would prefer a sort of some people have criticized this approach, but like a Health Canada FDA style approach, where you create a governing body who is responsible, staffed by experts, who is responsible for coming up with the requirements, the regulations, that sort of stuff. That is a much more appealing approach to me than just a regulation that has to be passed by whatever governing body you have in play. Uh, that appears to me like it can be more flexible. The issue with such a body is that when people are not elected, a sort of corporate capture has happened in multiple cases in the past. So it's not a foolproof solution either. But like I think you can regulate parts of it. It depends on the specific question. But I think that I guess like the last one, too strict regulation in terms of too much detail likely will be outdated or not apply, and not attempting at all. I don't think that's a good option. Like I don't think we should be. I don't think that should be even under consideration, but some people are pushing for that. Yeah.
Yeah, thank you. Yeah.
Okay, I think we're out of time, but I'd like to thank Abdalla today for joining us and challenging us with some of these questions. So if you'd like to contact him, maybe Abdalla, just throw your email into the chat there really quickly if you'd like to follow up or do further work with him. He's at the University of Alberta in Edmonton. And yes, we can contact you at any time. So thank you so much again, and thanks for attending, everyone. Bye for now.
Thank you.
Okay, bye.